Okay. All right. Hi, everyone. Welcome to the first Research Ethics and Policy Series lecture of 2026. I'm Holly Fernandez-Lynn, co-chair reps with Steve Jaffe. And today it's my pleasure to welcome Dr. Jason Karlawish for his lecture titled How the Alzheimer's Revolution Impacts the Responsible Conduct of Alzheimer's Research. I'll say a few more words of intro in just a second, but I just wanted to flag that next month on February 10th, we're going to have a lecture from Alexis Thompson from CHOP on sickle cell gene therapy, but we will not be in this room. We're going to move to our new office space at 3600 Civic Center Boulevard, and we'll be in room 11-102. Just like Richards, you need a pen card to get into that building. So we will see you there on February 10th. We'll still be hybrid on Zoom, but we hope you'll join us in person and we will give you lunch if you do that. You can find a full list of the upcoming reps speakers on our website, and we're always happy to take suggestions for people you'd like to hear from in the series. Quick reminder about some of the online resources from our department. We have a series of short research ethics courses available for free continuing education credit. Some of these can also be used to satisfy the research ethics training requirements at Penn and CHOP. And then a quick thank you to our co-sponsors and to Lisa Bailey, as always, for helping the reps run so smoothly. And now I'm happy to introduce today's speaker. Dr. Jason Karlawish is a professor of medicine, medical ethics, and health policy and neurology here at PSOM. He directs many things, the Penn program on precision medicine for the brain, co-associate director for the Alzheimer's Disease Research Center, and co-directs the Penn Memory Center, as well as the Alzheimer's Disease Research Center's Outreach, Recruitment, and Education Core and its research ethics component. Dr. Karlawish's research focusing on aging, neuroethics, and policy. He's investigated issues in dementia drug development, informed consent, quality of life, and many other areas. His most recent book is titled The Problem of Alzheimer's, How Science, Culture, and Politics Turned a Rare Disease into a Crisis and What We Can Do About It. And he's also the author of a new series on STAT called Neurotransmissions. And amid all of that, he made time to join us today for this lecture. We are recording today's session. It will be posted to the Department of Medical Ethics and Health Policy's website. And when the lecture concludes, we'll have the opportunity for those of you who are online to post questions in the chat, or you can also unmute and ask questions yourself. Okay.
Thanks, Holly. Yep. Good to be here. I'd like to think I'm a draw, but nice to lose lunch. So, I just get a bit of a sense of who you are. I know many of you, but before you just do a quick kind of poll of it. So I, as you can tell by some of the things I do, part of my work is as a physician to diagnose and treat the diseases that cause dementia. Alzheimer's, of course, is the marquee disease, and we'll talk more about the nomenclature there. It's getting increasingly more fascinating. So what I'm going to talk about, I'm also sort of living and working with both as a researcher and some of the things about ethics, speech research, but also as a clinician diagnosing and treating patients. And the word revolution is often overused, in medicine and science. Like everyone's child who's an honors student, everyone's discovery is revolutionary. But truly, it is a revolution. It's just incredible how in the last 2-3 years, my practice has changed, almost to the point where I look back. What was going on 3 years ago was historical, and it was really kind of static for the sort of 15-20 years that I did it. And then everything changed all at once. I know many of you, but is there anyone here who's an IRB member or serving on an IRB? Good. Okay. Anyone here who does research in this space, broadly construed, social science, biomedical, clinical trials? A bit. Okay, great. Well, I just want to get a sense of that. And I have a hunch, and do not raise your hand, but who has exposure experience personally with this disease and its problems. This is probably about everyone in the room here. And so probably many of your motivations might be just that. So let me tell you a bit why this matters. So yes, there we are. So this is what I'm going to talk about. I'm going to tell you right now, I'm not going to talk about informed consent or capacity assessment. So that's a separate lecture if you want it. So first, why this topic matters. And it matters because we conceive of and think of individuals who have diseases that cause dementia, or that is to say who have dementia, even if you can't figure out the disease, as vulnerable And I kind of, my operational way I think about what we talk about when we talk about vulnerability is that an individual who is vulnerable is relatively or absolutely incapable or impaired in protecting their rights and interests. And so that begs the sort of question of, well, then who's not vulnerable? Because I have to make some comparison to make the judgment that they're at least relatively less capable than the other group. And for the purposes of I think grounding us in something substantive, I would just say certainly, in this case, it's adults who have achieved developmental milestones of adulthood and have a requisite suite of cognitive abilities that allow them to have an adult mind. Certainly that translates into the sort of marquee reason why they're vulnerable is they have trouble making decisions. They have trouble taking in new information, working memory, hold it, map it up to episodic and semantic memory, and produce a decision that seems to make sense. And that certainly is one reason why they're vulnerable: impairments in capacity to give informed consent. But there are other reasons why individuals who have dementia are vulnerable. Some live in what are called total institutions, otherwise known as residential long-term care, sometimes called nursing homes. And in these settings, the borders between the public and the private are entirely kind of morphed into something different. And other people sort of have charge of your life. The total institution concept was developed by Erving Goffman, and his marquee examples were prisons and boarding schools. Places where the public and private are all melded. And certainly for those who live in a total institution, aspects of freedom, liberty, et cetera, are to some degree challenged. There also may be in community-based long-term care settings, like an adult day program, et cetera, where similar issues might operate. Which leads me to, some have thought that they're vulnerable because other people take care of them, which is interesting. I've never thought of children as vulnerable because they have parents. In fact, I think they're vulnerable if they don't have parents. But nonetheless, there has been a literature around, and that the fact that people with dementia have caregivers, and caregivers are burdened, and they spend a lot of money on the care, and experience ambiguous loss, and living in the uncanny valley, that all those things make them a problematic decision maker on the part of the other person. I think we could debate that. I won't. My view, though, is that generally a well-meaning ethical caregiver recognizes that their interests are interdependent with the other person who has that they're caring for. In other words, if I make a decision that's willfully harmful for them, I'm going to have to deal with that harm. So I think that kind of checks whatever sort of concerns there might be about a caregiver being a reason why someone's vulnerable. Nonetheless, though, it does get to the issue of, we don't have, unlike children and parents, and parents, kids are essentially, I was going to say parents are the property of their children. I don't have children, but many people are parents who probably empathize with what I just said there. But yes, Holly laughs. But children are a property of their parents, and the law well recognizes that and vigorously upholds a parent's right to make decisions on the behalf of children, and is eager not to step in. In contrast, there isn't a well-reified legal infrastructure to say that someone who's a caregiver, which is totally socially determined structure and construct, is a legally authorized representative for someone. But nonetheless, I think it's kind of been widely recognized that given the role of caregiver, when properly in that role, that they can serve in a sort of LAR type role. But can get a little funky. For example, someone's married, which by the law of who is a proxy, namely spouse, in the typical hierarchy of medical decision making would be, but yet their dutiful daughter actually, or even make it even more funky, daughter-in-law is their caregiver. You can make an argument that, well, the decision needs to be made while we would go to the spouse because they are technically the LAR by kind of the hierarchy that the state sets up. You really ought to talk to that dutiful daughter-in-law because she's got a lot of insight about the person that's being recruited for research. I won't talk much about that either, because there's nothing that's been around for decades, and you can read about that. Another reason why they're vulnerable is that the quality of care for people, as vast as the problem of dementia is, and depending on how you define it, you can get to numbers that are like apocalyptic. There's 6 million people, there might be 7, and soon by 2030 there'll be 20 million, et cetera. You get to this apocalyptic demography. But despite that, the quality of care is kind of really quite variable and oftentimes really spectacularly lousy. I'm proud of what we've done at the Memory Center. and have been doing for decades now. And we still have a lot of room to improve, not only at our center, but in the health system. But boy, when I see what's going on out in the wider world, it can be really spectacularly horrible. And so that can lead to real issues of inequity, where research becomes the way you finally get care. Because there's no way I can get caregiver training and support unless I sign up for a project, that delivers that. So all those things add up to why I think this topic matters. Okay, let me now pivot and talk about the revolution in Alzheimer's, and then I'll talk about changing concepts of Alzheimer's and how they impact on the responsible conduct of research, namely what you say and what it means when you say it. The challenges of research that gathers real-world data, the sort of pragmatic clinical trial, embedded healthcare system type work. And then finally, I'll wrap up with talking about some of the challenges that clinical trials that are going to test new treatments face in light of the revolution. What's the revolution in Alzheimer's disease? You could say it in one word: biomarkers. Once upon a time, a diagnosis of Alzheimer's was haunted by uncertainty. It was always probable Alzheimer's. That was technically correct. And the only way I could say it was definite is you would have to die, because once you died, the neuropathologist could take out the brain, stain it, slice it, look at it, and say, this is Alzheimer's. More often than not, they would say, oh, it's other diseases as well, because co-pathologies are very common. Sometimes they'd say it is an Alzheimer's. In fact, sometimes it's a little more common than we now realize. And in some sense, the blood-brain barrier and the problem that you really can't biopsy the brain the way you can biopsy the liver, where tissue is tissue, et cetera, or the kidney. The blood-brain barrier and the skull really kind of metaphorically and literally protected the brain from our ability to figure out what's going wrong with it. It's fascinating. That's why Sigmund Freud kind of gave up on his neuroscientific approach to understanding mind and turned to analysis, because he realized there's no way I can study the sort of biology of this organ. Freud wanted to be a neuroscientist, but he realized I can't do it. You can't get into that organ. So he did what he did. But biomarkers have changed all that. And I can't tell you how just breathtaking it is that not just imaging biomarkers where you can see the pathologies in the brain. And I mean the pathologies, not representations of the pathology. A representation is on an MRI. Atrophy signifies that the disease is chipping away at the brain, but I don't know what that disease is. I have a hunch of what it is based on a variety of things, but I can now image the actual pathologies causing Alzheimer's, amyloid, and tau. But I can also run blood tests that actually detect those pathologies. The ROC curves aren't perfect, and but the technology is only getting better. And there are technologies now that allow me to measure synuclein, which is the pathology that implicates Lewy body disease. We're getting close to technologies that measure late TDP-43 disease. It is just spectacular. I can't tell you how I no longer make a diagnosis of probable Alzheimer's, because I can look at the pathology and just say to someone, you have Alzheimer's disease. That is the pathology in your brain, period. So that's just spectacular. I've undiagnosed people with Alzheimer's because they actually have a different disease. I won't detail that, but that's just how incredible it is. The second thing is anti-amyloid therapies. These are drugs that target amyloid, beta amyloid in the brain, and remove it, and have been shown in reasonably well-designed, randomized, placebo-controlled trials that they change the rate of progression and standard measures that we use to measure rate of change over time. And there are now 2 drugs that are approved by the FDA. Yes, there are 3. The one drug is called aducanumab. That's the third, but it's off the market now. And while I was a vigorous critic of that drug's approval as a failure of regulatory science and also scientific design, these other 2 drugs, lecanemab and donanemab, have data that I think, well, let's just say I prescribe them. I think that they're a viable option for people who have Alzheimer's disease. So these now, unlike the prior drugs that did not target the pathology of the disease, these drugs target the pathology. And if you look at what they do and the way based on how you measure it, there's a strong suggestion that they're having an effect on the pathologic process, that they're slowing down the pace of the disease, similar to how drugs, say for multiple sclerosis, target the disease process in MS and slow down the relentless progression of disability in MS. So that's a biomedical revolution. There's also now the beginning of a care revolution occurring, which is spectacular. And the bit that stands out to me, and every time I hear Joe Biden's name, I get the cold sweats. But I'll give the Biden administration credit that through Medicare's the Affordable Care Act's provisions, was able to implement what is a demonstration project called GUIDE, which I was meant to write down what it stands for, but it's an acronym. The D does stand for dementia, and the G stands for guide. So it's like guiding something. Anyway, it's a Medicare-based program that delivers caregiver support and education with reimbursement that follows to the healthcare system. Technically, it's a demonstration project, so after 7 years, it has to be reevaluated because the Medicare statute doesn't allow Medicare technically to deliver long-term care services and supports. I don't know how they got away with this. And given what's happened in the last year and 5 days and 1 month and all everything else, it surprisingly has not been cut, reduced, or gotten rid of. But it is an impressive national effort to deliver what has been lacking, which is long-term care services and supports to both persons living with dementia and their caregivers. And so together, biomarkers, anti-amyloid treatments, and what's on the horizon, as well as programs like GUIDE, really translate into a revolution in diagnosis and treatment. And it's in the context of that revolution that I think there are some challenges now to the responsible conduct of research. And so that's what I'll turn to next, having exhausted you with an extraordinarily long introduction. So the first topic is nomenclature, changing concepts of Alzheimer's. So this is off of alzheimers.gov, which is a federally funded website. I don't know if it still exists or not. I wonder what they've done to it. I'll stop. But anyway, it's a federal website that attempts to amalgamate information for the public about this disease. And this is a sentence from it. People with MCI, which is mild cognitive impairment, are at greater risk of developing Alzheimer's disease or a related dementia. I applaud the government's effort to write a coherent sentence about this, but this is actually technically incoherent, and I will explain why in the next slide. Slightly incoherent. Okay, dementia is a term that simply describes in an adult declines in at least 2 domains of cognition that are causing disabilities in daily activity over time. That's dementia, period. That's a simple disabilities in performing daily activity caused by progressive declines in cognitive and perceptual abilities. Okay. Mild cognitive impairment is cognitive impairments that are causing inefficiencies in daily activity. It takes the person longer to get things done. They may make mistakes and they catch them. Those are just what those 2 concepts mean, as simply defined as I possibly can. There are a variety of different diseases that cause both dementia and MCI. Alzheimer's is one of them. Lewy body disease is another one, just to kind of lay the ground like this. Okay. The problem is that in culture, the word Alzheimer's has probably about 3 meanings floating around right now. In its earliest form, when it came to be re-recognized in 1980, Alzheimer's was essentially synonymous with dementia. In other words, when a clinician said, you have dementia, you have Alzheimer's, they were sort of saying the same thing, because at that time it was felt that all dementia was Alzheimer's, and so it was all kind of the same thing. That was the general view, okay? And that view very much dominates, and it's translated into why people often say, what's the difference between Alzheimer's and dementia? Because that was, for a while, they were synonymous. Now, what began to happen was a recognition that, well, there are some other diseases that cause dementia. So Alzheimer's disease, is a clinical syndrome. It's a specific set of signs and symptoms that are explained by a pathology called Alzheimer's. And that was sort of the 90s into the aughts. And then the biomarker revolution that I told you about, I'm tying it together, said, no, Alzheimer's is the pathology in the brain, period. That's Alzheimer's, regardless of whether the person has dementia or mild cognitive impairment. And the point they're getting at is that you can measure the pathologies in the brain, and they're there. Why are we waiting for somebody to get sick to say you have Alzheimer's? That's Alzheimer's. So these are 3 very different constructs of what we talk about when we talk about Alzheimer's that are active in our culture as we speak. And so oftentimes when I read grants or look at research flyers, I see things like looking for people with Alzheimer's, and what they really mean is just dementia. Or what they mean are people who have the syndrome of Alzheimer's, or now more than ever, maybe beginning to look for, no, I want you to have the pathology. And so the pearl to take away is when you're reading recruitment flyers or informed consent forms, what are the words they're using to describe what they're recruiting? And often enough, they're sort of talking out of both sides, or at least 2 different meanings in the same document about what we talk about when we talk about Alzheimer's, or what we talk about when we talk about dementia. Mild cognitive impairment was created at the Mayo Clinic in 1999 by a group of well-meaning, thoughtful researchers who found out that there's this group of older adults who have memory problems, don't yet have dementia, who over time develop Alzheimer's disease. Remember, it was the 90s. And so MCI was a risk factor for Alzheimer's. And if you look at their original paper, they list the MCI group, and the next group is the people who progress to Alzheimer's disease. And so this led to, and it's still hardwired into our culture, there's this thing called MCI, which is and they say, well, does the person have MCI or do they have Alzheimer's? And that comes from this view that MCI was a risk factor for Alzheimer's back when Alzheimer's was all dementia. There's another view of MCI, which you can see that I'm promoting, is MCI is just like dementia. It's a syndromic label that can be caused by a variety of different diseases. So it is incorrect to say that someone has, do they have MCI or Alzheimer's? You would say, do they have MCI or dementia? That's right. Good. You just passed my class. But you can see flyers and recruitment flyers that talk about MCI or dementia or Alzheimer's disease, for example. So back to our federal government, people with MCI are at greater risk of developing Alzheimer's disease or related dementia. In that same website, Alzheimer's is often talked about as a pathology, very specific pathology. And so you can see here, they're sort of playing with two concepts of Alzheimer's going on in this recruitment flyer. It's not really a recruitment flyer, it's just an education site. Not just, it is. What you'd want to say is that people with MCI are at greater risk of developing dementia, or people with MCI are at greater risk of developing dementia caused by Alzheimer's or other diseases that cause dementia. Now I can see that, well, if you do a AI on that, the literacy level's too high. We have to, nonsense. So this is a good example of, you could imagine this in a recruitment flyer, for example. And the problem is that people go to the doctor, go online, and they read all these different meanings of these terms. And so there's this sort of pleonexia of terms and understanding out there, which lead to this sort of general confusion. We'll get through it, I think, in the end, as always is the case, because there's a robust business model behind biology. I think biology will win, and we will think of these diseases as biologic. And, we'll fight over whether dementia is stigmatizing or not. I think MCI will fade because I just think it's so funny to label someone with it, because it's sort of like telling them back what they just told you, which is they have cognitive impairment, but it's kind of mild. And you say, yes, indeed, you have mild cognitive impairment. That's kind of amusing. So the point I'm getting at with this part of the talk is, and I read I used to read them. I got rid of the study section. But I used to be on a study section, and I would read, they would give me the Alzheimer's grants, and I would read the grants, and you would see this just total confusion of nomenclature on the part of very well-meaning young investigators, where they were using these words in very different ways, et cetera. What I didn't mention, and it's my fault on the slides, is the current term of art out there is AD/ADRD, which stands for Alzheimer's disease and Alzheimer's disease related disorders or dementias. It depends on where you read it. It's fascinating. So that's even yet another term that is out there. And a lot of it reflects the fact that we don't have an umbrella term. We don't have a cancer. We don't have the ability to say, you have cancer. And they say, well, what organ is it in? We don't have the ability to say you have, and it is caused by Alzheimer's. I was a proponent of saying you have a neurodegenerative disease. I was told it has too many syllables and Americans can't handle more than two. So whatever. Anyway, so I'll stop. Okay, so why it matters, the revolution, nomenclature. Okay, now we pivot to hang on a minute. I got this right. Hang on, oh, yes, I'm sorry, I forgot. So with this revolution in nomenclature, and the fact that there are studies going on that are labeling people with pathologic Alzheimer's, et cetera, a big challenge now that studies face, that IRBs and investigators have to tackle, is the return of results. So it is the case now that there's large cohort studies like the health and retirement study paid for by the federal government, which collects blood on all the people in that population-based study. And now they can run blood-based biomarkers for Alzheimer's. Now, this is fascinating and wonderful because they could give us a population estimate of the prevalence of Alzheimer's pathology in the United States, which would be incredibly valuable. But what that also means is that people in HRS, there's a blood sample somewhere in Michigan that basically is going to tell them whether or not they have Alzheimer's. And HRS also has data on your cognition. They do a telephone screen or something like that, and they interview a caregiver, and they have a pretty good algorithm for figuring out whether you do or don't have cognitive impairment. So there are people in HRS that they know have cognitive impairment, and they also know they have Alzheimer's. And as the more blood-based biomarkers come along, they'll know others. So you have these cohort studies that have just been gathering the data, passively watching, recording things, who now can tell people you have Alzheimer's. And I would argue there's a strong warrant to think about whether you need to return those results. I mean, imagine that using a study that like could pretty reasonably know whether or not you had breast cancer. You know, but no, we're not going to tell her. She'll find out if she goes to her doctor. But you know, but that so that you're up against, I think, something like that. I think that is extremely problematic to run a cohort study without a plan to return results, particularly if you know they're cognitively impaired. If you don't know they're cognitively impaired, you can kind of hide behind, well, we don't know anything about the meaning of that result until we know cognitive function. So, but that's sort of hiding behind a wall that's, you know, pretty porous and is going to fall down. So that's one challenge, and it's a huge challenge that I think faces investigators and IRBs, the return of results, particularly biomarker results, and also cognitive testing. In the space of what's known as preclinical Alzheimer's, namely, I know you're not cognitively impaired, but I know you have the biomarkers of the disease, this issue will also loom very large. Now, the argument now is, well, there's nothing you can do about it. You know, no treatments yet. There are some under study that will be read out soon, but I think you could make a very strong case for individuals to know that result because many of us tell us, I would really like to know if I'm at risk of developing that disease to make some plans, et cetera. I can take a question because I see it here.
But then you also run to the problem of insurance and employer discrimination. Because what is available to me, I can be essentially forced.
That's a comment, not a question.
I can be forced to.
Okay, great. Okay, good. Yep, that's a challenge. So the next topic I want to talk about, so nomenclature, biomarker revolution, treatment revolution, and the implications for cohort studies. The writing of recruitment and informed consent documents all, I think, face novel challenges. The next topic is the screening, recruitment, and eligibility for research assessment topic. So this one is, okay, I'll explain this. So there is now a large federally funded effort, as well as an increasing effort by the part of healthcare systems and insurance companies, et cetera, to improve the quality of care, the delivery of care. We've got to diagnose people and deliver better care to them. All that is good. That's a good thing. I'm not complaining. The challenge, though, is that there is a vast underdiagnosis of dementia and certainly of mild cognitive impairment. About 40% of people in the United States who have those conditions are not diagnosed. And about 20% who are diagnosed don't know it. There's actually an under-recording of the diagnosis in the chart. In other words, the doctors will bill for it, but they won't put it in the problem list. So you have, if you want to do research to improve the quality of care, the standard approach would be to say, well, look, I want to go into the healthcare system at Penn, and I want to find everyone that's on anticholinergic medicines, and I'm going to do a deprescribing intervention to get them off those harmful medicines. You just go in, they're in the medical record, and these rules here allow you to do that. You can screen for people for studies by peeking into the medical record now, according to these rules, and you're good to go. And you could even be more comfortable with like diagnoses of like heart failure or a host of other diagnoses, which are robustly diagnosed in America and robustly charted. But if you said, I want to improve the quality of care at Penn Medicine for people with dementia, you would have, and you said, I'm just going to hit Epic and just look for all the codes. What I've suggested to you is you're going to vastly miss a host of individuals. Moreover, if you then probe who are the kinds of individuals that we are going to get, you're going to get like the people who come to the Penn Memory Center. And I can tell you right now, we tend to enroll folks from sort of the wider suburban area. And we have a vast disparity, although we're making great efforts to try and correct the disparity in the social, economic, and other characteristics of the people who get diagnosed. And that's a general national finding that you see, that underdiagnosis, and it's even more radically underdiagnosed in a host of individuals for whom access to care and continuity of care is a challenge. So what I'm setting you up for is a well-meaning, pragmatic trial that wants to sort of improve quality of care, is going to face some challenges about delivering that pragmatic intervention to the people that could get it. And especially for that kind of research, unlike a clinical trial, a lack of a representative generalizable sample is sort of a no-go from a validity perspective. Like, that's not a pragmatic trial. That's a sort of like a clinical trial that enrolls like a select group of people who show up at your site. So the solution for this is of course, we're at halfway through the lecture and I get to mention AI. So there is. Good. I just mentioned AI, but I prefer to call it machine learning because it gets at the fact that it's not an intelligence, it's a machine. But you can develop machine learning algorithms, or there are machine learning algorithms like E-Radar, which is the EHR Risk of Alzheimer's and Dementia Assessment Rule, E-Radar. And what E-Radar does is kind of neat, and I'm laughing, is it can pull all sorts of data from the medical record that predicts with a reasonable probability that you have dementia. And the data are classic kind of machine learning, every piece of data you can get, and then it's obviously been validated. And it's things like how old the individual is, frequency of ER visits, certain diagnoses, various medicines, et cetera. And the result is this predictive algorithm that has pretty decent receiver operator characteristics to say you've got dementia, you don't. So the challenge there, and you can imagine if you were a pragmatic clinical trialist, you'd say, that's great. Let's get E-Radar. That'll identify everyone. We'll look at the chart for diagnoses, but we'll use E-Radar, and then we'll really up our catchment, and we'll do great. But now let me sort of present the challenge. I told you there are some people who are diagnosed, but there's a big chunk of them who don't know it. So if I got the contact letter, hi, I'm a well-meaning pragmatic clinical trialist that would like to enroll you in my study of caregiver interventions for people with dementia, there's a 1 in 5 chance to say, I don't have dementia, or he has dementia. No one ever told us that, even though it's, quote, in the medical record. So that's a problem. And if you do it with E-Radar, it would even be more of a Christmas present that you weren't expecting to come your way. Namely that, no one ever told us this. Dr. So-and-so has never told us this. So you face a challenge here to use this ability, this rule that allows you to efficiently dive into the medical record, get data, and recruit someone. Moreover, you already had a hint. The third challenge is, I said, well, we'll just send the letter to the caregiver, right? Who the hell is that? Epic at our medical center does have emergency contact, but it does not have a specific field for caregiver. That is not a specifically documented entity for someone. That is the assumption that the emergency contact is a caregiver, would be a caregiver, could be a caregiver. Exactly. Your shoulder shrug is perfectly, I don't know, whatever. Recruiting, quote, through the caregiver, you have no confidence if you say, well, we'll just send it to the emergency contacts, that you're actually sending it to a caregiver. So suddenly your well-meaning, embedded, pragmatic clinical trial that was going to deliver a thoughtful intervention to improve education and training for people with dementia and their caregivers is running up into a host of just disasters. People getting letters. What? My mother has dementia. Why did you send this to me? Why did you send that to my daughter? How, you're just imagine. So the whole thing is a disaster. So what do you do? How do you get this study going? Well, I think I'm going to give you my solution. I think the best you can do is to tightly link your well-meaning effort to in-person clinical visits. So I know now, I have the list of people who the algorithm has picked up, and I will be at the practice working with their clinician to say, here's some information that suggests that Mr. Karlawish is potentially really at high risk of having dementia. There's this clinical intervention you're supposed to do to screen for it. If you do this, we can then also offer this study to him. Okay. And you have the advantage back to the revolution. I didn't mention this of the annual wellness visit, which is is actually written into statute that you have to detect the presence of cognitive impairment, any cognitive impairment, on an annual basis through the Medicare annual wellness visit. They don't tell you what test to use, thank God, but that's in there. So you can probably limb together with the annual wellness visit and in clinic intervention, elide your way to perform and do your clinical intervention, your pragmatic clinical trial. I think another solution here would be to do what Epic should be doing, which is have a very explicit field in Epic that says, does this person have a caregiver, et cetera, and maybe even operationalize what that means, an available, trustworthy, and reliable person to support the person's care. You could call it what's the term, Emily, we also came up with? Care partner, caregiver, care partner. What's that? Yeah. Who's part of your life? Who's the person who's available, reliable, and trustworthy? I mean, the word caregiver is very problematic. I'll just give you a little personal anecdote. I don't know if my mother is watching, but hi, Mom. But my mom tells a story that her husband then had mild cognitive impairment. And he actually was seen at the memory center where I work. And the staff call her up to, make the appointment. And they said, well, as your husband's caregiver, we'd like, and my mother, wait a minute, my mother can be a bit of a spitfire. Says, I'm not his caregiver. What are you talking about? Because, and she was, I suppose, technically right, although she's the one that made all the appointments. I wasn't going to fight with her, but my point was, I think it's a vivid example of how the caregiver term is one that people take on, and it's not something that you can easily hand out to people. They might not embrace it. I certainly have had even people who admit my relative has dementia. Well, I really didn't think of my caregiver until I had to start washing him. Whereas, 5 years prior, they're paying the bills, they're shopping, they're totally running without them, the person would be dead. Okay, so my last bit, and then we have some time for questions, and you can be finishing a little early, is the design of clinical trials to test new treatments. So this is a total switch of topic, but back to the anti-amyloid therapies, donanemab and lecanemab. So the question here is you have therapies which are effective. They do not cure the disease. They don't halt it. The curves show a rate of slowing. They're highly variable in how an individual responds. And we lack the ability to tell an individual if you are responding based on a biological measure, which is difficult, but I think will change over time. And the therapies do have risks, namely microscopic bleeds in the brain. And if those are not detected, they can lead to swelling, to leakage of fluid from the areas where the bleeds are occurring. The term of art, by the way, for that was coined is ARIA, which stands for amyloid-related imaging abnormalities. You can tell I don't use that term because I don't like using a term that's a term for a term. Namely, it makes it sound like the problem is the imaging. Like there's something wrong with your imaging. I find that very disturbing. So I just say to people that the drugs can cause microscopic bleeds and swelling, as opposed to ARIA. But that's just me, maybe. Anyway, so in light of those facts, the question is, if I'm and the drugs are approved for people with mild cognitive impairment or mild stage dementia caused by Alzheimer's. And I'll give the FDA credit for kind of getting closer to a nice coherent language there. So the question before us is, in a study of a new drug for individuals with mild cognitive impairment or mild stage dementia, what is the control group? You compare your new drug to you have to compare it to something. You can't, if you don't compare, you're not doing a clinical trial. Do you compare it to placebo or do you compare it to existing therapies? And this is, this is like bioethics 101, research ethics 101. And I'll just tell you what I think the answer is, and then we can maybe walk back. I think a placebo control is perfectly fine, but it has to be placebo control only. I think a 3-arm trial, you get new drug, existing drug, or placebo is morally problematic. So let me explain that. I think that the drugs are sufficiently not beneficial or sufficiently beneficial, sufficiently risky or not risky, sufficiently hassle-filled or not hassle-filled,
that a reasonable person could say, I'd like to take it, but this is not for me. It's too risky, not enough benefit, and intravenous infusions every whatever week. It's just, I can't do this. I can speak personally. I just, when I heard about these drugs, pondered it for a family member. I'm like, we're not doing it. It's just too much work. So in those kind of settings, I think you can make a case for, yeah, you can have a placebo-controlled trial that compares new promising drug to placebo, assuming new promising drug has something that really makes it more attractive, at least theoretically, than existing drugs. And the new drugs that are in the works for amyloid actually are more attractive. They lower dosing, lower side effect profiles, and potentially therefore greater efficacy. So I think a placebo-controlled trial right now is perfectly legitimate. I think the problem with a 3-arm trial is it's sort of saying, well, you can get existing treatment, which it sounds like you might want, or promising new treatment, or in a blinded setting where you have no idea what you're getting, you might actually have 18 months of placebo. And I think that that's actually very problematic to put someone in a study like that. I guess you could say, well, they gave consent, and I get it, but back to vulnerability issues, it's a really tough consent process if you're enrolling people with mild stage dementia. I can tell you from my own clinical work, many of them get what they're doing, but it's a struggle for them to understand. And if you set a nice assessment of capacity, you'd be knocking out a number of potential subjects because they just don't quite get what they're enrolling in. So for the reasons of vulnerability that I outlined in the beginning, as well as a risk-benefit balance that I just can't get my head around, I think a 3-arm trial is very problematic. But they're out there, actually. But a placebo control for now is good. How will we know that it's time to move from placebo to active controlled trials, which is the case for many diseases that are of the same severity and cultural fear as Alzheimer's and other causes of dementia, when they go abroad? That's what you'll know. You'll know when you suddenly notice that the companies are going over to India or the Ukraine, if it still is there, or maybe they'll go to Venezuela. Sorry, whatever. But you'll know that's your signal. And that happened in MS. In MS, in the early years of MS, there were these effective therapies for multiple sclerosis. They were risky. Benefits were still not ironed out. And so for a long time, MS carried on with placebo-controlled trials. And what began to happen is the investigators would gather at the study meetings and they'd say, this is a real bear to recruit for. And the companies began to go over to India and other countries and do the MS trials there, which are highly problematic on a number of levels, which I think folks in this room can better explain than I can. And indeed, in the last several years, the MS field essentially said, the standard now is an active controlled trial, unless you've got a population for which they clearly can't take or otherwise existing therapy. So there's still room there, but really the default now is active controlled trials. So that, and I think the field of neurodegenerative disease will go there. You can't, but not see that assuming the treatments improve. So how the Alzheimer's revolution impacts the responsible conduct of research. I trust what you are picked up on is, I'll go back to my beginning, that the changing concepts of what we talk about when we talk about dementia, Alzheimer's, are a rapid flux such that consent forms and recruitment flyers and patient education materials really need to be scrutinized. The best of intentions can lead to incoherent language. That revolution has also created the real need to rethink the return of research results. It is becoming increasingly problematic to gather data that say someone is developing a disease that causes them to lose their mind and say, well, it's a research study, we don't have to let them know about it. That is a very problematic position to have for those cohort studies. The real world data runs smack into the problem that we still have, which is the quality of care is highly variable. I hope I've outlined to you that, best of intentions research that seems quite minimal risk and what are we worried about could blow up in your face if you don't think carefully about what to do. But I do think you can do it. It's just going to require greater investment, quite frankly, of time and money to be able to deliver those diagnostic labels. And then finally, the development of new treatments have us in this new era where it will be not a question of whether, but when we have a disease that's considered treatable, and putting people in a study that does not give them access to treatment is default unethical, subject to sort of aspects of the particular individual that make them, not eligible for current treatments.
So that's the revolution and how I think it's going to change things. We have a little bit of time for questions, both in person and online. Holly, do you curate the online?
Yeah.
All right, so it's all open for discussion or questions, et cetera. Thanks a lot. Really enjoyed the opportunity.
Latecomer, sorry, 50 minutes to find a parking spot. Ridiculous, but it is what it is. So I am living this as we speak, as I have a 92-year-old mother who has dementia, who's under the care at Penn Memory Center here in Philadelphia. She's also part of the GUIDE program. I don't know if you're familiar.
We talked about it.
You did.
Yeah.
As my mom's son, I am thankful for programs like GUIDE. What I'm not thankful for is the lack of quality home care. All right. I pulled my mom out of a memory care center. And had I not done that, she'd probably be dead today. All right. It's very unfortunate. I've gone to 16 of these personal care memory care centers. My mom's been in 2 memory care centers, 1 personal care center. I now have her living on her own in an apartment complex. It's not a 55+ apartment complex. Matter of fact, most of the residents there are very young. All right. And I have care coming 6 days a week when they show up from the hours of 11:30 to 5:30. But one of the things I'd like to share from my own personal experience is there are, and maybe you talked about this, and I apologize again for being late. And then finding this building is a challenge too. I have sensors inside my mom's apartment. A company called Envoy at Home. They're across the river in Cherry Hill. I don't know if you're familiar with them, but I have been very, very pleased with this sensor system. It keeps my mom's dignity, quite frankly. I really don't want to see my mom naked in the shower. So that's one thing. And then there's another company called, and I'm sure there are others, Alzheimer, but I did a lot of research on these companies, that has a camera system that shows people inside as stick figures. Again, keep people's dignity. Okay. So, I think there are a lot of things that can be done. I think one of the things that is very difficult for me is trying to advocate for my mom is
what you're doing now.
Keeping her active, keeping the mind especially active, having a proper diet. I can actually see the difference in her when she's not taking her B12 vitamin. Most of the meds, and I know you put a couple of dementia meds up there. I don't know if they're the same meds, but my mom is on a couple of dementia medications. And what I'm trying to do with my mom, and so far, knock wood, it seems to be helping, is avoid the path that her 99-year-old sister, who just passed a week ago Sunday, 11 days shy of 100th birthday. Okay. So I'm looking at longevity with my mom. What I don't want to have happen is my mom to be, for all intent and purposes, brain dead, not know the people that she's surrounded by. Okay. So under the care of Dr. Vaishnavi and his team, he's part of Penn Memory Care. My mom, believe it or not, I don't really see a difference since she started on the drugs. She was mild to moderate dementia 4+ years ago. It's coming on 5 years ago. All right. She's 92, closing in on 92 and a half. And she's still mild to moderate.
So
let me make sure there's enough time for other people.
Yes, I apologize.
Yeah, no, actually, you arrived at a perfect break point there, because you've nicely summarized the challenges related to quality of care, to accessing diagnostic services, and to the emerging therapeutics. So you basically gave a nice personal, vivid summary of everything the revolution I talked about. So thank you very much.
Thank you. My apologies.
Yeah.
For being
No, there's no apology. I think you nicely showed the audience, look, if I gave this talk 10 years ago, no one would have showed up and gave a testimony like you did. They were too embarrassed to do it. They were too scared to do it. And they didn't know what the hell was going on anyway. So, so anyway, you're a good,
I don't think anybody should be in.
You're a good foot soldier in the revolution. So thank you.
Thank you.
Yeah, no, I really appreciate it.
Took me longer to park than drive down here. Came on Bucks County.
Other questions?
Sorry.
No, sorry.
anyone?
One, Jason, which is if you could talk a little bit more about what we know now about the amyloid hypothesis now that FDA has approved 3 drugs on that basis, right? Should we continue studying products on that surrogate? Should we be expecting drugs to move immediately now into regular approval based on clinical endpoints? Where are we now?
Yeah, great question. So there's sort of 2 streams to that. One's a sort of scientific question, which is, has the amyloid hypothesis been validated? And I think the answer is those 2 experiments and other studies that have been done on humans suggest that if you do something to amyloid, you do change the pathophysiology. Does that mean that that is Alzheimer's and that's all? No, I think there's probably other mechanisms to go after, and data suggest there could be effective, namely tau, inflammation, et cetera. Okay, so I suppose I'm sort of saying, yeah, I mean, targeting amyloid seems to have an effect. Is that all Alzheimer's? No. So that's one point. I think the more interesting question is the regulatory science question you're getting at, because the approval of aducanumab was on the basis of accelerated approval using amyloid lowering as a surrogate that was considered adequate evidence to put the drug into practice with the requirement to gather, quote, more data down the road. And both one, but not the other of the 2 drugs that are currently being sold were also approved under accelerated approval, although it's interesting, the one that was approved under accelerated approval didn't really bother to market until they got full approval. The bottom line answer I have is I don't think lowering amyloid is enough of a signature to say this drug works and should be approved and get more data, because there's too many drugs that do that but then don't work, because I think what they don't do is they're not doing it at an adequate dose, et cetera, that we could debate. Not debate, but well, we could debate it, but discuss that science. I actually think that lowering amyloid measured by PET scan is a surrogate of a deeper surrogate that we haven't yet figured out. And behind that, it might be toxic oligomers. I'm not sure what. So I think it's an indirect surrogate. It'd be like, I'm not measuring blood pressure. I'm measuring something else that blood pressure causes, like headache. And that would be my proxy for blood pressure. You should just measure blood pressure. I'm not sure if that metaphor made any sense. So in summary, 2 cheers to the amyloid hypothesis is my view. So not none, but not 3. Yeah.
I see Susan Ellenberg online.
Hi, Susan.
Susan, can you unmute and ask your question?
Okay. Yes. So I was interested in your comment that the 3-arm, that a placebo-controlled trial would be ethical, and I can appreciate that. I think some people might debate it, but I think there's a good argument to be made that they're still ethical. I don't understand your point that a 3-arm trial has ethical problems. I think it has feasibility problems because, as you said, there are side effects and logistical issues with the existing drugs, and people may not want to take them. And if you have a 3-arm trial, people may not be willing to be randomized, possibly get the existing drug. So can you explain a little more why you think it's unethical to do that kind of trial as opposed to simply maybe it's not feasible?
Yeah, 2 reasons that intermesh. One is I can't get my head around what that favorable risk-benefit balance assembled together. I don't get the equipoise position of promising new drug, existing drug, placebo. That's one. And the fact that the subjects, if they have MCI and mild stage dementia, are vulnerable on the basis of impairments in capacity, combined together to say that is an ethically problematic design. There's 2 arguments together is what I'm advancing.
Okay. Maybe we'll have to have another discussion offline, because I'm not sure I still get it, but go on to someone else.
Okay. Well, no, so it's probably the risk-benefit balance issue, because I think we agree that the capacity issue is there. I mean, I don't think you're debating that. So new therapy, yeah, that looks attractive. I wouldn't mind getting it. So someone says, okay, well, I have a trial that makes that available. Great. Okay. And then there's this promising other drug, which, while not proven, seems to maybe have a better safety profile, et cetera. Okay, well, I would take a chance at your new drug or the existing drugs. I can see that as oh, by the way, there's another chance, a 3rd-arm chance, that you get neither of them. And I'm trying to get my head around someone to say, I wouldn't mind being on current therapy or your new promising, but I also wouldn't mind being on no therapy. I find myself trying to get my head around what set of values would arrive at that in a way that's coherent. I mean, people can have whatever values they want. I mean, we're witnessing that now. But I can't get my head around that. That's a sensible, coherent risk-benefit balance to offer.
Okay, I think we'll just agree to disagree, because I think what you're really talking about is a question of feasibility, that people who want something may not want something else. If it's ethical to use a placebo, would you say it would be unethical to do simply an active control trial? I would find that problematic, because the existing drugs probably be hard to define a non-inferiority margin, but in principle.
I think an active controlled trial could be designed in an ethical manner. Yeah, sure.
All right.
All right, let's go to another. Susan, I'm gonna let another person in the room ask a question.
Yeah, I was just wondering if you look at recent FDA clinical trials, we're getting really good at reducing amyloid in the brain. And that has, statistically significant differences when you look at cognition and measures of daily living. But I wonder, in your clinical opinion and experience, is that meaningful for patients or even perceptible?
So the question is, how do you measure benefit in a clinical trial for people who have symptomatic disabling cognitive impairments as opposed to preclinical? And the measures of choice are measures of cognition and measures of what's called function, the ability to do daily tasks. Sometimes they put the two together in some quirky little omnibus measure that combines both. And so then it's of course a number, and then there's a difference between the two groups, and there's a mean and all that. And of course the problem is, unlike say a study of heart failure or cancer, where endpoints are death or progression to an obvious next stage of heart failure, that's an endpoint that's extremely incoherent. And what you're left with is debating effect sizes and whatnot. And I think ultimately, and it's very difficult to explain those to patients and et cetera. I think a solution which no one's embraced is, if we really want to better stage these diseases clinically, and there's a movement to do that, what is stage 1, 2, 3, to really look at transitions to stages as probably the most coherent endpoint that people could understand. And caregivers get that. They'll say, what stage is my mom at? And you say, they're at the mild stage, and this is what it's described by. What would be moderate? Well, when these events happen, that would be moderate, et cetera. The reason why people don't like that as an endpoint, first of all, it takes a longer time to go from a stage to transition. So that's a longer trial to conduct. And, there's an argument that you're letting people get more sicker over time, to prove your drug works. And, that is, I'll say harmful, but you're accruing more harm to individuals so as to gather that data. So the field has struggled with this question since the first trials were ever done, by the way. So namely, I don't mean to dismiss your question as not novel, but it remains an enduring problem in the field, It will only get more interesting when the drugs that are being studied in people who are unimpaired are tested. And there are 2 clinical trials now that are doing that. One of them measures stage transition. That's Eli Lilly's study of donanemab. So they will try to have an argument of, we prevent the onset of dementia, which is actually very attractive from a marketing perspective. The Eisai trial, which is lecanemab, measures cognition, and I think they're going to have a very hard time explaining, the difference on the ADAS, not the ADAS-Cog, the ADCS pack battery as being clinically meaningful. So that will cause, and I think if both drugs work, I guarantee you in the end, this is going to be settled by insurance and cost, because they'll go after whichever drug's cheaper, for understandable reasons. Yeah. So, yeah.
Well, what do you think about the ethics of doing gene therapy, for example, there's work trying to change macrophages to Christchurch?
I'd have to know more to even begin to comment on what the ethics of the issues are. I don't follow the gene therapy world, so I confess ignorance. Yeah.
You mentioned the Eli Lilly to prevent dementia.
Yep.
Do you mean prevent, or do you mean slow
the time to onset? Yeah. So the word prevention is problematic. Some people say if you prevent a disease, you never get it. Whereas it's about risk reduction. It's probably the more precise term. You caught me. Thanks. Well, we're at top of the hour. Oh, one more question, then we'll wrap it.
I just want to know do you think it's
more ethical to, like, you brought up the biomarkers and some people like not knowing that they have it. Do you think it's more ethical to exclude them in clinical trials, or do you think it's worth like the chance of them finding out, you know, like you said, the parent, like through a caregiver being like notified that they do have biomarkers for dementia?
A little, so what kind of study are we speaking of here?
Like the one you were just talking about, like you said, you run into the problem of people not knowing that they have it, but they get called to be enrolled, for example.
Right, yeah, those would be clinical diagnoses, but I could imagine an even more problematic thing is we had bank serum, because Penn banks a lot of blood. We have freezers full of blood somewhere in Lancaster, I think. And I suppose we could go and defrost them and measure p-tau. Well, actually, we've done that. We've measured p-tau 217 in the health system, the patients, not the staff. But it would be very problematic to say, hi, we defrosted your sample, tested for p-tau 217, and you have elevated p-tau. You know, would you like to be in our study? I think you'd have to, I'd have a full stop on that one before I would say, yo, let's do it. I'd want to kind of get a little bit better thinking on that one. So that even more amplifies my problem, the problem that I was raising, which is, if that p-tau 217 was done clinically and in the clinical blood bank, because we're ordering it now, you could do that study. You know, you did have this test, your doctor Karlawish ordered it. That's why I'm calling you up. But it's when it's in a biobank that you can then go test. That would be very problematic. Yeah. So good question.
All right, thank you, Jason.
All right, thank you very much, Holly. Thanks. I enjoyed it. I think